A woman came into my clinic 2 years ago. Sharp, funny, still working part-time. Her daughter had found a brain MRI report online and booked the appointment. The report used words like atrophy and white matter changes. By the time I saw her, she had already told her employer she might need to step back. She had already started grieving. Her brain was fine. What wasn't fine was what that piece of paper had done to her in the 3 weeks before she sat down across from me. I'm Dr. Anika Mehta. I've been in neurology long enough to know that the damage from a cognitive test doesn't always come from what it finds. Sometimes it comes from what it makes you believe before anyone has actually looked at the full picture. That is what I want to talk about today, and I want you to stay for the 5th test especially. Because that's the one families ask for themselves with the best intentions. And it's the one I've seen do the most quiet, lasting harm. Here's something medical school doesn't prepare you for. When a doctor sees something unusual on a test result, the system is built to act on it. Not sit with it, not wait. Act. Think of your aging brain like an old house. A skilled home inspector will always find something. A hairline crack here, some settling there, pipes that have seen better days. That doesn't mean the house is falling down. It means the house is old. But once that report is written, the pressure to do something about it begins. And that pressure has a cost, one that most patients never see coming, and one I'll explain in detail when we get to the 3rd test, because that's where it matters most. The first test on this list is one family's request with the best possible intentions, and that is exactly what makes it so hard to push back on. Test number 1, routine brain MRI. Let me describe a scene I know well. You're in your early 70s. You missed a name at dinner, forgot where you'd put your glasses twice in 1 week. Your daughter reads something online and she's worried. She loves you. So she pushes for a brain MRI. Just to rule things out, she says. Just for peace of mind. You go in. You lie still in that loud machine for 45 minutes. A few days later, the report comes back, and the words on it sound alarming. Mild cerebral atrophy, white matter hyperintensities, age-related changes, small vessel disease. Those phrases sound like a catastrophe. But here's what they actually mean when a neurologist reads them on a report from a patient in their 70s. This is a 70-year-old brain. Radiologists write reports for other doctors. They are not written to be read by patients sitting at a kitchen table with a cup of tea. The language is technical, and it sounds like damage, even when what it describes is completely expected. White matter changes show up in the majority of healthy older adults. A brain that has lived 7 decades will show the marks of those decades. What troubles me most is what happens after the report arrives. The primary care doctor feels obligated to refer. The neurologist orders follow-up imaging. The family starts watching every pause, every repeated question, every moment of forgetfulness through a new lens, a lens of fear. And that fear, as I just explained, is not neutral. It has a biological cost. Meanwhile, the MRI has told us almost nothing useful. I have seen patients with scans that looked genuinely alarming, who were sharp, engaged, managing complex finances, and living full lives. I have seen early dementia in patients whose scans looked remarkably clean. The picture and the function do not reliably match. So what should you do instead? Come in and let us look at how your brain actually works. A simple in-office assessment, recalling 3 words after a delay, drawing a clock face, a few short questions about planning and attention, tells us far more about real cognitive health than any image. An MRI belongs in the workup when someone is getting measurably worse over months, getting lost in familiar places, or can no longer manage daily tasks. Mild forgetfulness alone does not meet that bar. But at least an MRI requires a referral, a machine, a clinical setting. The next test on this list requires nothing but a phone and a quiet moment of fear. Test number 2. Online cognitive screening quizzes. You've seen them. They look official. They have clinical-sounding names, timed sections, numbered scores. Some of them are genuine research instruments that were designed to flag large groups of people who might need further evaluation. And that is exactly the problem when a single worried person takes one alone at midnight. These tools were built for populations, not individuals. A low score on a population screening tool means one thing: this person should be evaluated further. It does not mean this person has dementia, but that is not how most people read their result. Here is what actually tanks your score on a timed cognitive test, completely independent of your brain health. Fatigue, anxiety, poor lighting, reading glasses left in the other room, a stressful week, 1 glass of wine 3 hours earlier. Any one of these can pull your score down significantly, and most people are not taking these tests on a calm Tuesday morning after a good night of sleep. They are taking them because something frightened them, which means they are already anxious, already tired, already primed to perform below their baseline. Now here is the part that concerns me most as a neurologist. There is a well-documented phenomenon called the nocebo effect, the opposite of placebo. When you believe something is wrong with your cognition, that belief itself changes how you perform on subsequent real tests. You second-guess answers you would normally have given without hesitation. You lose confidence mid-task. The self-fulfilling dimension here has a neurological basis, and it is not small. If something is genuinely worrying you, I want you to do this instead. Write down 3 specific examples of what you noticed. Not a vague sense of fog, but actual moments. Then bring that list to your neurologist. Concrete, functional observations from someone who knows their own daily life are worth more to me in a clinical conversation than any online score. The next test is different in kind. It comes wrapped in real science, and that is precisely what makes it so difficult to question. Test number 3. Amyloid blood tests. Now we move into territory that is more recent, more sophisticated, and in some ways more complicated, because it carries the weight of genuinely exciting science. There are now blood tests that can detect proteins associated with Alzheimer's disease years before symptoms appear. This is a real scientific achievement. I want to be clear about that. These tests represent decades of serious research, and they have a meaningful role in medicine. But that role is not the same as taking one because you are 63 and anxious about the future. Here is what you need to understand. Having these proteins present in your blood does not mean you have Alzheimer's disease. It means your brain is producing or accumulating certain biological markers. Many people carry a significant burden of these markers and never develop dementia. The reason is something called cognitive reserve. Think of cognitive reserve like a savings account your brain has been building your entire life. Every book you read, every new skill you learned, every rich conversation, every year of education, those were deposits. Some people have built up enough reserve that their brain can absorb considerable biological change and still function beautifully. The presence of a marker is not the same as the presence of disease. So what happens when someone with no symptoms gets a positive result on one of these blood tests today. There is currently no approved treatment that clears these proteins in people who are not yet symptomatic, which means a positive result gives you a label without a solution. What it does give you is years of anticipatory grief, changes in how your family sees you, potential complications around insurance, and a steady background hum of cortisol, which, as we discussed, is the last thing your hippocampus needs. This test has genuine value. It belongs in the evaluation of people with clear progressive symptoms who may qualify for newer therapies. It belongs in carefully designed clinical research trials. Context is everything in medicine. Before you agree to this test, ask your doctor one question. If this result comes back positive, what will we do differently tomorrow? If the answer is that nothing changes yet, then you are accepting real psychological risk in exchange for information you cannot yet act on. Test number 4, the MMSE. The Mini Mental State Examination, the MMSE, is the most widely used cognitive screening tool in the world. It is also one of the most routinely misused. I want to be fair to this test. In the right setting, administered carefully, it gives us useful information. The problem is that it is almost never given in the right setting anymore. I see it administered in emergency rooms while someone is in pain. I see it given to patients who just received frightening news in the same appointment. I see it squeezed into the last 5 minutes of a rushed primary care visit where the room is loud and the patient has been waiting for an hour. Here is what legitimately tanks your score on this test, with no relation to your actual brain health. Poor sleep the night before, uncontrolled pain anywhere in your body, a new medication started in the past week, untreated hearing loss, anxiety about the test itself, low education levels, and English being your second language. Any one of these can move your score into a range that looks like cognitive impairment. When several of them are present at once, the number you get back is measuring your circumstances that morning, not your cognition. And what follows a low score? A referral, then another assessment, then a conversation about driving, then a conversation about living arrangements. All of it set in motion by a number that reflected how hard that particular Tuesday was, not who you actually are. There is also a problem in the opposite direction. The MMSE is not sensitive enough to catch early real decline in highly educated people. Someone who has spent their life reading and thinking and solving problems will often score perfectly on this test, even when something genuinely worth investigating is beginning. The test misses them entirely, offering false reassurance when a more careful look would be appropriate. If cognitive screening is warranted, ask for it under conditions that are fair to you. Rested, comfortable, not mid-crisis. The MoCA is generally more sensitive and more useful. But more than which tool is used, timing and context matter enormously. And that brings me to the 5th test, the one I said to stay for, the one that is the most invasive, the most definitive sounding, and the one I have seen do the most quiet, lasting damage to people who were not yet sick. Test number 5. The lumbar puncture. I am talking about a lumbar puncture, a spinal tap, to analyze cerebrospinal fluid for Alzheimer's biomarkers, requested not because of clear progressive decline, but because a family wants certainty. They have read about it. They feel that knowing is always better than not knowing. I understand that impulse completely. It comes from love. But here is what this procedure actually involves. A needle is inserted into the spinal canal to draw fluid. This is not a simple blood draw. Real risks come with it. post-procedural headaches that can last days to weeks, infection risk, anxiety in the days of waiting for results, and the not insignificant psychological weight of having undergone something invasive while trying to figure out if your mind is slipping. And then the results come back. Let's say they show elevated markers associated with Alzheimer's pathology. What happens next is rarely what families imagined when they asked for certainty. Because pathology is not disease, many people with abnormal spinal fluid live cognitively intact for a decade or more. What the result actually delivers is a biological signal whose timeline and trajectory we cannot yet reliably predict for any individual person. But here is the shift I watch happen in families after a result like that. The person is no longer quite themselves in the room. Their opinions are second-guessed. Their preferences are quietly overridden. Their autonomy erodes, gradually, sometimes years before any real functional change. Because a number on a lab report has rewritten the story of who they are. This test belongs in the workup of someone with clear, documented, progressive decline, where the results will directly inform a treatment decision today. It belongs in clinical research, where the data serves a larger scientific purpose. It does not belong in the hands of a frightened family looking for a guarantee that medicine cannot give. Before agreeing to this procedure, ask one question. Am I symptomatic enough right now that this result will change my treatment plan this week? If not, the risk-benefit calculation does not favor moving forward. So after all of that, here is what actually matters. I want you to walk out of this conversation with 3 specific questions to ask before any cognitive test. What will this test find? What will we do if it finds something? And how will that change my daily life? The measures that genuinely matter are functional ones. Can you manage your finances? Navigate a familiar route? Follow a complex conversation? Learn something new and hold on to it? These are the real signals of cognitive health, and they do not require a needle or a machine. If you have specific concerns, write them down. 3 concrete examples of what you noticed. Bring that list to your neurologist. That conversation will do more for you than any test ordered without it. Now here is what I want you to sit with for a moment. The tests we covered today can leave people with 2 equally harmful outcomes: unnecessary fear about a brain that is functioning well, or false reassurance that delays a conversation that actually matters. Everything we talked about today, the cortisol, the hippocampus, the cascade, it can all be quietly undone by something most people are already doing. Something that feels responsible. Something that feels like good self-care. When people leave an appointment carrying that kind of worry, the most common thing they do next is try to take control in other ways. And for most seniors, that means reaching for supplements. There is a combination of supplements that millions of seniors take every single day, specifically to support brain and cognitive health. And the research now suggests that how and when you take them together may actually be working against you. Not because either one is harmful on its own, but because of what happens when they interact in your body. That is what I cover in the video that is on your screen right now. If protecting your brain matters to you, and I think it does or you wouldn't still be here, then that is the logical next place to go. Don't let what you've just learned go to waste by missing this piece. The next video is already there. Click it now.